Hello, everyone. My greetings to all of you. I hope you are doing great. Okay, I cannot see the comment. So we are going to learn today the integrated pattern of pharmacology, and we will also be learning about the integrated pattern of microbiology. These all are non-clinical subjects only, and we are going to learn how questions are being framed. So I hope you are doing great, and I hope anatomy session and physiology and biochemistry sessions, these sessions have helped you. Okay, chalo, we are going to start with the first question of pharmacology. Okay, pharmacology, first question for you people. See this question, and after that you tell me the answer. After taking an anti-epileptic drug, a patient of partial seizure gets the following reaction as shown in photo. Which blood investigation is must to do before a patient is supposed to be started on this medicine? So here, actually, this is a picture-based question. I can say that this is a question of medicine. I can say that this is a question of pharmacology. Yes? Okay, now you tell me. So what is your answer? Please write your answer in chat box, like in comment section. Okay, TK, chalo, let me solve this question for you people. Okay, so after that you will understand how this question is framed. Okay, what exactly examiner wants to know from you people. Okay, when question is here, okay, right in front of you, at that time, okay, like at that time, like you have to, at that time you have to integrate the knowledge. So first of all, after seeing this question, I can say that, okay, my patient has used one anti-epileptic drug. Okay, and this photo, when I see, okay, this looks like a Stevens-Johnson syndrome and a Stevens-Johnson syndrome. So I have 100% clue from the photo that my patient had Stevens-Johnson syndrome after taking anti-epileptic drug, and especially my patient is having partial seizure. Fine. So now I can recall my pharmacology knowledge, that what I have learned in my pharmacology, how many anti-epileptic drugs were able to cause Stevens-Johnson syndrome. Actually two. One was the carbamazepine. Okay, one was the carbamazepine and second was the lamotrigine. Right now? So one was the carbamazepine and second was the lamotrigine. Fine, okay. But as we all know that, okay, drug of choice for the partial seizure is, okay, this is carbamazepine. Okay, no? So fine. So now I can make one diagnosis here that my patient must have used, okay, this anti-epileptic drug, which is known as the carbamazepine. Okay, which is known as the carbamazepine. And all of you, I hope now you have one idea that, okay, the drug which your patient has used, that was the carbamazepine. And the grave side effect, okay, the grave side effect of the carbamazepine is what? Agranulocytosis. Agranulocytosis means after using this drug, there will be destruction of what? After that, there will be destruction of white blood cells, neutrophils, and all. Agranulocytosis. Fine. So when I know that grave side effect of carbamazepine is agranulocytosis, at that time, so before I start my patient on the carbamazepine, I should recheck his WBC count, complete blood count, complete blood count. Easy to understand? So now everything is clear. Okay, so now everything is clear. Okay, fine. If okay, when I know that carbamazepine can cause agranulocytosis, okay, agranulocytosis, which is actually a life-threatening condition for the patient. So every time before I start a patient on carbamazepine, I have to check what? I have to check complete blood count, complete blood count, so that I can see the level of WBC. If already, okay, if already level of WBC is less, at that time I will not be using carbamazepine. So what is the normal count of WBC? Okay, 4,500 to 4,500 to 11,000. Okay, no, suppose if my patient is having WBC less than 3,500, at that time I should be very, very careful. I should not be using, I should not start my patient on, I should not start my patient on carbamazepine. Easy to understand? Okay, fine. I have given you one clue here. See, like this was the one question, but on the basis of this drug, so-called the carbamazepine. Okay, fine. Now, if I ask you one question that my patient is having seizure, my patient is having partial seizure, along with that, my patient is also having psychotic symptoms. He is having all symptoms like schizophrenia. Okay, no, this is a psychiatry topic. Now I'm going to integrate this pharmacology and medicine question to psychiatry. Now you tell me, if my patient is having epilepsy as well as psychotic symptoms like schizophrenia, okay, no, and as we all know that drug of choice for resistant schizophrenia and overall actually one of the best drugs for psychotic symptoms in schizophrenia is clozapine. I hope all of you know this clozapine. So now you tell me carbamazepine and clozapine. If my patient is having some bleeding disorder, if my patient is having less WBC, less WBC from the normal count, carbamazepine can be given with clozapine kya? Or carbamazepine can be added with clozapine? Yes or no? Because what I'm teaching you, this is all about pharmacology. I hope now this pattern you are going to forget, that you are going to memorize. Okay, what you used to do before. Okay, drug of choice for this, drug of choice for that. Okay, you used to memorize all the drugs. Now the days are gone. Okay, when one-liner questions used to be asked. Now I'm asking you all drugs question, all pharmacology questions related to clinical presentation. I'm asking you, carbamazepine can be added with clozapine? Or normally, even if you do not know, even if you don't know the WBC count, are you going to add carbamazepine and clozapine together? Yes or no, please? No? Okay, why? Dr. Bhamini? See, always understand that even for the clozapine, please remember, even for the clozapine, okay, the grave side effects are agranulocytosis and myocarditis and seizure. But even with clozapine, there will be agranulocytosis. So carbamazepine is also going to cause agranulocytosis, means okay, destruction of WBC and neutrophils, right? Now fine. So even clozapine is also causing agranulocytosis, and the carbamazepine, that is also causing agranulocytosis. So these two drugs should not be combined. Okay, this is also one question. Easy to understand. This is also one question. Fine. I hope you remember some points related to clozapine, that clozapine is the drug of choice. Okay, this is the drug of choice for resistant schizophrenia, schizophrenia. Okay, now for resistant schizophrenia, this is okay. Clozapine. Okay, clozapine के बारे में चलो कुछ और some extra points I'm telling you. Clozapine was the first second generation antipsychotic drug. Okay, this was the first drug which was synthesized. So this is actually what? Atypical antipsychotic drug. Atypical antipsychotic drug. Atypical means what? Second generation antipsychotic drugs. Fine. Like haloperidol. Haloperidol is the first generation antipsychotic drug. Fine. Which we were using for schizophrenia. Haloperidol. I hope you remember all these points. Fine. No? So, okay. So these are the questions which can be framed out of this topic. Fine. Chalo, fine. So see, in this question, when I was talking about anti-epileptic drug, see, there are some anti-epileptic drugs. When I talk about the carbamazepine, is it possible that carbamazepine can cause anemia also? Anemia also? Yes, but repeatedly asked question. See, here also there is a point of confusion. Okay, yes, anemia can also be caused by two anti-epileptic drugs. One is phenytoin. Second is the carbamazepine. But which type of anemia? Okay, no? So please understand that phenytoin will cause megaloblastic anemia, and the carbamazepine will cause aplastic anemia. These are your questions which can be framed out of this topic. Okay? Phenytoin will cause megaloblastic anemia, and the carbamazepine will cause aplastic anemia. So see, out of this question I have asked you, I have framed right here multiple questions. So in this way, what I suggest you that when you start preparing, when you start learning pharmacology, please learn the medical aspect, learn the clinical aspects of every drug. Okay, fine. So please understand that whenever you are going to start a patient on the carbamazepine, CBC test, complete blood count test is mandatory. It is mandatory. Okay, easy to understand. Chalo, next question. See here, a topical prostaglandin analog for glaucoma treatment is given OD at night. Okay, side effect of this drug is shown in photo. All right, what is the mechanism of action of this drug? Side effect I have shown you here. Even if I would not have given you this photo, I think this was very easy to understand. Ki prostaglandin analog drugs, okay, these are anti-glaucoma drug. So what is the mechanism of action? But for your convenience, I have given you side effect also. Even prostaglandin analog was not mentioned in the question. On the basis of this side effect, you could have solved this question. So first of all, now you tell me, what do you see in this picture? What do you see in this picture? I mean, what is the side effect? Please tell me, what is the side effect? See, are you able to see different iris? See, this iris color and this iris color. Both are different color. Both iris are different in color. Heterochromia iridis. Heterochromia iridis, right? Very good. Dr. 𝗵𝗵𝗶𝗶𝗺, very good. Heterochromia iridis, right? So what is happening here? After using a drug for glaucoma, my patient is having different color in his both iris. Fine. This is called as heterochromia iridis. On the basis of this photo, I have made a conclusion that, oh, okay, fine. Side effect of the drug is heterochromia iridis, and the drug is anti-glaucoma drug. So I hope you remember that for the glaucoma, we are using even miotics. We are using CA anhydrase. We are using beta blockers. We are using CA inhibitors, carbonic anhydrase inhibitors like acetazolamide, and beta blockers like betoxalo, right? And we are using prostaglandins, and we are using miotics. All these drugs are used for glaucoma. All these drugs are used for glaucoma, but okay, mechanism of action of different drugs, okay, mechanism is different. See, for prostaglandin analog, this is going to increase uvoscleral outflow, and miotics, this is going to increase trabecular outflow, and beta blockers and CA inhibitors, these are going to do what? These are going to decrease the water production. These are going to decrease aqueous production. So first of all, let's talk about prostaglandin. My patient has used prostaglandin analog. I hope all of you remember like latanoprost, bimatoprost, and the travoprost. Fine. So what is the mechanism of action? Increase uvoscleral outflow. Uvoscleral outflow. Okay, so side effect of prostaglandin analog like latanoprost is what? Heterochromia iridis. Heterochromia iridis. And even, you know what? See, even there will be, sandy eyes will be there. Sandy eyes. Okay, there will be peritoneal fat dysplasia. Okay, periorbital fat depletion will be there. So all these side effects are of latanoprost, or we can say the prostaglandin analog. So here, what is the answer? Answer is B. I hope this clinical question is clear. Okay, like this is clear to all of you. See, in this way, you know what? On the basis of picture, on the basis of clinical presentation, you have to solve the question. You have to solve. Okay, you have to recall the mechanism of action of the drug which you are using for your patient. Easy to understand? Chalo fine. We are proceeding to next question now. A new drug of COVID-19. Okay, we are going through this COVID-19. So let's talk about COVID-19 here. A new drug of COVID-19 is launched in Indian market. After clinical trials of this drug, it is distributed in multiple cities. After a few days, complaints of adverse reaction are reported to the resident doctors of hospital, through which software resident doctors are required to update all adverse reaction to inform National Coordinating Center and Center for Drug Standard Control Organization, CDSCO and NCC. Okay, so these are the centers for, these are the centers for pharmacovigilance, right? Okay, for monitoring the adverse reaction of any new drugs or any drugs in our country. Okay, na? Fine. So basically what I am asking you in this question, see, very easy question. What is happening here? There is a new drug. Okay, there is a new drug in market. After that, this new drug was prescribed to so many patients. Okay, so distributed to patients, and patients started using it. Okay, fine. After a few days, so many patients are complaining, sir, with, because of this drug, I'm having this problem and that problem. So patients are reporting what? Adverse reaction. Adverse reaction to whom? Okay, to nearby medical college and hospital. So which doctor is supposed to write all these adverse reaction? Okay, let's say, you know what, like suppose same drugs were distributed in multiple cities of India, like in Odisha, like in Manipur, like in UP, Bihar, okay, New Delhi, Mumbai, anywhere. Okay, fine. So what is happening here with the, because of that drug, same adverse reaction is being reported by patients, okay, to every district medical colleges and hospital. So resident doctors, they are supposed to report, they are supposed to update these, okay, like, okay, these adverse reaction on a software. So this kind of question, okay, this kind of question is being framed these days related to software, because we are working with modern medicine, and with the modern medicine, we are having what? Okay, we are working with technologies also, right? So these days they are asking some questions related to software also. So resident doctors are going to report, update that, okay, like in my hospital also 50 patients have reported the same side effects. Fine. So now the doctor is going to report on a software. On a software which is called as 𝗵𝗔𝗶𝗄, 𝗵𝗔𝗶𝗄, which is called as 𝗵𝗔𝗶𝗄. So what is happening here? Okay, fine. So what is happening here? See, with the help of this 𝗵𝗔𝗶𝗄 software, now this will be reported to, see, this will be seen by NCC. Okay, no? This will be seen by National Coordinating Center of Drugs. And when multiple adverse reaction will be there, then NCC is going to report, CDSCO. Center for Drug Standard Control Organization. Easy to understand. So now what kind of actions will be taken by CDSCO? Okay, now Center for Drug Standard Control Organization, when they come to know that, okay, so many side effects are coming there, okay, no, so then they are going to, inform the patients, okay, do not use this drugs, okay, do not use this drug. They are going to inform doctors, do not prescribe these drugs. They are going to ask the manufacturing companies to withdraw the drugs from market. Okay, no? So easy to understand. So this is, so here in this question, name of this software is what? 𝗵𝗔𝗶𝗄. Okay, this is used for what? Pharmacovigilance. Same thing, suppose, like, see, 𝗵𝗔𝗶𝗄, this software is used for the national market. Okay, no? Intercities of India. But if, okay, see, if this type of adverse reaction is supposed to be reported or updated on international market, okay, no? On international platform, then, okay, there is a different software for international market. Okay, that is called as 𝗵𝗔𝗡𝗋. 𝗵𝗔𝗡𝗋. Okay, 𝗵𝗔𝗡𝗋 is for international market. Okay, for international market. So on the basis of 𝗵𝗔𝗶𝗄 and 𝗵𝗔𝗡𝗋, some questions can be asked. Okay, chalo fine, aage badhte hain. Next question, a 60-year-old female is on long-term medication for peptic ulcer disease. Okay, so here I'm talking about peptic ulcer disease. As we all know that peptic ulcer disease, this is the most common cause for what? Upper GI bleed, right? No, upper gastrointestinal bleed. Okay, peptic ulcer disease like gastric ulcer and duodenal ulcer. Like gastric ulcer and duodenal ulcer. Fine. Okay. So my patient who is 60-year-old, she is on long-term treatment with, okay, treatment for peptic ulcer disease. Okay, she presents to your clinic with severe pain in pelvic region with inability to walk. X-ray is done and following picture came out. Which of the following drugs can cause this? I can see in this picture that there is fracture. I can see in this picture, in this X-ray, that there is fracture at the neck of femur. There is a fracture. I can see that. Now I have to analyze with the basis of this X-ray image and clinical condition of my patient. This X-ray is saying that my patient is having fracture. Okay. After that, or maybe, you know what, see, this question can be asked in different manner also. That a patient who is on long-term treatment for peptic ulcer disease. See, for the peptic ulcer disease, we are using which drug? PPI, है ना? Proton pump inhibitor like pantoprazole, rabeprazole. Okay, for and PPI we are using for peptic ulcer disease, right? Okay, like a rabeprazole and pantoprazole. I hope all of you know this point. Fine. So what is happening here? Side effect of PPI inhibitor, proton pump inhibitor. See, you know what is happening? PPI, long-term use of PPI cause depletion of calcium. Depletion of calcium. After that, patient is having what? Osteoporosis. Osteoporosis, softening of bone, osteoporosis. So if I have old patient who is on long-term medication, who is on long-term treatment for peptic ulcer disease with the proton pump inhibitor, and a proton pump inhibitor, she can suffer from osteoporosis, and she will give this history that, sir, you know, in washroom I fell down. After that, I'm not able to walk. Okay, my family has brought me here. Fine. So basically, she is having severe pain in hip. So first investigation to be done on a patient who fell down, who was on long-term treatment with proton pump inhibitor like pantoprazole and rabeprazole. First investigation to be done is what? X-ray pelvis. Okay, this is your one more question. First X-ray to be done is what? X-ray pelvis. Okay, easy to understand. Okay, so when I have seen the X-ray of my patient, I can see that my patient is having fracture of femur part, femur neck. Then I have to recall, out of these four drugs, side effect of which drug is having osteoporosis where hip fracture can happen? So answer is what? Rabeprazole. I hope all of you know that some points related to PPI I want to share. Yes, I hope all of you know that. Okay, PPIs means what? Proton pump inhibitors. Okay, no, so these are the drug of choice for peptic ulcer disease. Okay, fine. NSAID induced ulcer. Okay, stress ulcer, Zollinger-Ellison syndrome. Okay, Zollinger-Ellison syndrome. Fine. So please understand that overall, please understand, okay, pantoprazole is the most acid stable and rabeprazole is the most acid labile PPI. So these are some of the extra points which I have added here. I just wanted to show you that what kind of questions they can make out of PPI. Okay, no, so this can be the severity of, okay, this can be the severity of complication. And on the basis of this severity, this kind of questions can be framed also. Okay? Next question. An African patient is presented to your clinic with complaints of severe abdominal pain, nausea, vomiting, and 4 episodes of diarrhea with bleeding. Which of the following treatment protocol is not suitable for this patient? Whenever you are facing this kind of question, please mark this point not. Okay, no? Not. After that, so now you are thinking that, okay, African patient is there. So this can be the case. Okay, so this can be the case of the traveler's diarrhea. On the basis of Africa, you are making this conclusion. Okay, fine, chalo. Okay, now you answer me this one, please. So when I talk about the traveler's diarrhea, you are thinking, chalo, loperamide, loperamide is drug of choice. Okay, loperamide is drug of choice for traveler's diarrhea. But you should read the question again, and then you should mark the answer. I have asked which of the following treatment protocol is not suitable for this patient. So see each and every option carefully. See, when patient had 4 episodes of diarrhea, okay, 4 episodes of diarrhea, so patient is having dehydration for sure. So I will start him on IV fluid. Yes, okay, so option number A is correct. Fine. Okay, then he is having severe abdominal pain, nausea and vomiting also. So yes, you know what, at that time there will be severe bloating and all. Fine. At that time, I will give injection of pantoprazole and ondansetron along with IVF. Okay, this option is also correct. When I'm thinking that my patient is having severe diarrhea, okay, severe diarrhea, bleeding is also there. I can think that, okay, patient is having bleeding as well as diarrhea. At that time, I want to stop the what? I want to stop the infection. I will add metronidazole also. Yes, and metronidazole. I am not going to start my patient on loperamide. Why? Because my patient is having a diarrhea with bleeding. My patient is having diarrhea with bleeding. Diarrhea with bleeding. Now, do you remember some points related to loperamide? What is the mechanism of action of loperamide? How loperamide works? Loperamide is good. Okay, see, I tell my students that, okay, loperamide will, okay, lock and block. Okay, now this is going to, okay, like this is going to do what? Okay, lock the intestine and block, okay, like this. So there will be further constriction. So how it is working, please understand that this is actually a mu receptor agonist. How it is working, it is going to decrease intestinal motility and secretion. How? This is going to increase anal sphincter tone. So this is going to increase the tone, okay, like this. So there will be further constriction. So please understand that. See, whenever you are going to give loperamide to any patient and you are not adding one antacid, and after that, after using loperamide, patient is saying that, sir, I'm having some kind of pain, spasmodic pain. Why? Because loperamide works in this manner. This is going to constrict, lock and block. So when it is going to do like this of intestine, what will happen? If it is bleeding, there will be more bleeding. Then no, there will be more bleeding. Fine. So please understand that. Please understand that whenever patient is having diarrhea along with bleeding, do not give loperamide. Do not give loperamide. Answer is C. Answer is C only. Answer is C. Means do not give loperamide because patient is having bleeding. So that's why please understand that in any inflammatory bowel disease, okay, no, like inflammatory bowel disease is there. So there also, and whenever diarrhea is, okay, diarrhea is associated with bleeding, at that time loperamide should not be given. Fine. So let's learn some more point related to loperamide. This is the treatment. Okay, this is the treatment for the non-secretory diarrhea like irritable bowel syndrome, irinotecan associated diarrhea. Means this is an anti-cancer drug, and this is also used for the traveler's diarrhea. Okay, so that is different. But when bleeding is there, do not use loperamide. I hope this is clear to all of you. So you know what, I can see that all of you have done mistake here. Okay, loperamide is different. Okay, fine. Next question. A 26-year-old male asthmatic patient presents to you for the routine follow-up. He is currently on albuterol, salmeterol, and corticosteroids, all via inhaled route. The patient is compliant with his medications, but still complains of episodic shortness of breath and wheezing. The peak expiratory flow has improved since last visit, but is still less than the ideal predicted values based on age, sex, and height. And then you have added 𝗏 in his treatment regimen. What is the mechanism of action? Basically, in this big question, I am asking you what? Mechanism of action of montelukast. See, this question was asked in JIPMER also. So why I'm sharing this kind of question, why I'm discussing this kind of question, that this kind of question, okay, these kind of questions are being asked in MCI these days. Okay, no, so they are framing in a clinical fashion. So now what is this? So now I'm asking you what? I'm asking you the mechanism of action of montelukast. Now you give me the answer. So basically, montelukast is what? Leukotriene inhibitor. And a leukotriene inhibitor. This is, now you tell me, from where leukotriene is made. I have added some point, like some points of biochemistry as well here. So this is a question of medicine, pharmacology, some part of biochemistry also. Therefore, please understand that leukotrienes are synthesized from arachidonic acid by the action of 5-lipoxygenase in many inflammatory cells in the airways. Okay, so montelukast, zafirlukast, and pranlukast, these are what? These are the competitive leukotriene inhibitors. These are leukotriene inhibitors. Okay, so please understand that even, like, see, I hope all of you might be knowing that, okay, whenever there will be wheezing, whenever there will be chest congestion, even during corona also, okay, no, see, even, okay, during COVID medicine also, okay, montelukast is added. Why? Okay, montelukast is added so that, okay, like there will be bronchodilation, and patient will be, okay, no, so patient will be able to, okay, breathe easily, right? Fine. So here what? Here answer is what? It blocks receptor for certain arachidonic acid metabolites. Answer is C only. C. Fine. So this is all about pharmacology. See, you know what? I have given you just basic orientation that what kind of questions can be framed, how pharmacology questions can be asked in clinically integrated manner. Now let's discuss some questions of microbiology. A 2-week-old patient has conjunctivitis, which later developed into respiratory distress and pneumonia. Chest X-ray showed bilateral lung infiltrates. 𝗬𝗎C count was 14,300 per deciliter. Which of the following is most likely organism? So basically, I'm asking you one question here that a pediatric. Okay, so this is the question of pediatrics. Okay. Means I have to understand that one bacteria which can cause conjunctivitis as well as pneumonia, out of these 4, which bacteria you are understanding? Okay, which bacteria you are anticipating that, okay, this bacteria can cause eye infection as well as lung infection? Answer me, please. Okay, options are, okay, gonococcus, second is chlamydia trachomatis, third is streptococcus agalacti, 𝗵𝗵 influenza. So overall, when I see all these 4 options, I see only chlamydia trachomatis. I see chlamydia trachomatis, which can cause conjunctivitis as well as pneumonia. So please understand that at the time of delivery, okay, during the time of delivery, see, infections during the pregnancy, this can be transmitted to infants during delivery. So please understand that approximately 20 to 30% of infants, they are exposed to chlamydia trachomatis in the birth canal. And first of all, this will develop what? Okay, patient will develop conjunctivitis, and approximately up to 10 to 15% further after a few days or few weeks, okay, they will develop what? Pneumonia. So please understand that chlamydia trachomatis, okay, chlamydia trachomatis, this is the only bacteria out of these 4 which can cause eye infection as well as lung infection here altogether. Fine. So when I talk about chlamydia trachomatis, this is very, very important bacteria. See, this is the bacteria which can cause, okay, no, which can cause the trachoma. So I can say that this bacterium, this is the most common, this is the most common agent for infectious blindness. Okay, no. So when I talk about, when I talk about the trachoma, in ophthalmology, I remember one part, okay, one that is called as safe strategy. safe strategy, this is the treatment protocol. Sometimes they're asking in safe strategy, what does S stands for? S is for the surgery, and then antibiotics, fine, then facial cleanliness, and then environmental cleanliness. Okay, fine. Now, so you know what, why I'm teaching you all these points? Please understand that whenever you are learning a non-clinical subject, please understand that each and every bacteria, every virus, all microorganisms are very, very important and related to the related to one microorganism, which other infections can occur. How you are able to correlate this chlamydia trachomatis to pediatrics, how you can correlate to ophthalmology, how you can correlate to respiratory medicine. Fine. So, like some microbiology is one of the most important subjects, right? See, minimum number of questions from microbiology in MCI as per the weightage is approximately 13. Sometimes they are asking more than 15 also. Okay, no? Fine. So I hope this question is clear to all of you. Next question. A patient comes after a dog bite with hydrophobia, tearing and altered sensorium. You suspect rabies in this patient. Corneal impression has been taken. What test will you do on it for most accurate diagnosis? So basically here diagnosis is 100% clear. Okay, this is written here that patient is having rabies. Okay, patient is having rabies. All right. So basically out of these four options, which is most specific and sensitive for rabies virus? So this is related to the investigations which we are learning in microbiology also, right now, for rabies. So which one you are going to perform here? See, RT-PCR test, RT-PCR. See, in a case of rabies, RT-PCR can detect genome of rabies in CSF, saliva, okay, no, CSF, skin, saliva, and brain tissues. So please understand that RT-PCR, this is highly sensitive and specific for the rabies virus. See, why I have asked you this question, that sometimes they are asking you which investigation we have to perform here. RT-PCR these days for the pandemic disease, very, very important, right? For the corona. So they can ask you, overall RT-PCR is the best overall. Okay, most specific we can say, right? No? Fine, easy to understand. Okay, when they are going to ask some question related to rabies, please understand that what kind of questions they can frame. Okay, they can frame. See, whenever there will be laceration, are you going to give a tight suturing? Answer please, yes or no. Are you going to give a tight suturing? See, whenever in a case of rabies, dog bite case you are getting, whenever there will be laceration, fine. At that time, I am asking you, are you going to give a tight suturing there? Suturing, I'm asking, suturing. Answer me please, yes or no. In a case of rabies, tight suturing should never be done. Should never be done. Okay? Should never be done. But yes, if there is big laceration, then you have to do very light suturing, just to approximate it. Okay, no, fine. And some other question what they're asking related to rabies. Okay, so what is the days of rabies vaccine, right? Fine. So these all questions can be asked from PSM. Okay, fine. ARV. Anti-rabies vaccine. ठीक है ना? तो number of days concept for 0, 1 and all है ना? ये सारा चीज you are going to learn from PSM. Okay, no? Fine. चलो. Next question, a patient with BPH. BPH means what? Okay, benign prostate hyperplasia. A patient with BPH was admitted in hospital for 3 weeks. He subsequently developed suspected catheter-associated UTI, urinary tract infection. Urinary tract infection. Tip of the catheter was sent for culture and was grown on blood agar. After 24 hours, the blood agar shows the appearance as shown here. I'm talking about this one, right? What is the most likely causative agent for the UTI? So this question is framed in a clinically integrated manner. Okay, in a clinically integrated manner. So basically, I'm asking you the organism which has caused UTI because of the catheter, and because of the Foley's catheter here. And after that, when that microorganism was grown, appearance is something like this, which I have shown here. Answer me, please. So what I see here, that the growth is something like this. Okay, growth is something like this. There is concentric swarming growth. Okay, there is concentric swarming growth. So out of these four, which microorganism is showing the concentric swarming growth? Actually, this is what? Answer is what? Very good, very good. So swarming motility, and especially if if situation is like that, if there is swarming motility is fine, I can understand that, but especially there is a concentric swarming growth. It is shown by Proteus. It is shown by Proteus, especially Proteus mirabilis. But if they would have mentioned, suppose without this picture, if they would have mentioned some other question, but what, please understand that if a microorganism is showing, or if a bacteria is showing non-concentric swarming growth, which bacteria is then non-concentric? I'm asking you separate question. Okay, so which bacteria shows non-concentric swarming growth? It is shown by Clostridium species. Clostridium. Take a Clostridium. So see, like on a single word, your answer will be changed. So you have to look for each and every small point here. Fine. So this kind of motility, frequently asked question. Okay, frequently asked question. See, repeatedly they are asking, see, this motility is shown by which bacteria, this motility or that motility. So if I ask you one time, falling leaf motility. Falling leaf motility is shown by which bacteria? Falling leaf motility, or which parasite? Actually, which parasite, I should say, which parasite, right? Now, which parasite? Okay. Okay, this is shown by Giardia lamblia. Okay, this is shown by Giardia lamblia. Fine. Okay, fine. So when I ask you, what about the darting motility? What about darting motility? See, these are your one-liner question. Okay, these are your one-liner question. Okay, darting motility. Okay, when I write darting motility, answer me please. Okay, which microorganism or which bacteria shows darting motility? Darting. Answer me please. Okay, fine. This is shown by Vibrio cholera, right? Vibrio cholera. Okay. Okay, no? Fine. And darting is also shown by the Campylobacter also, right? Campylobacter also. Okay, chalo, theek hai. And a very frequently asked question about that. Where do you see the tumbling motility? Where do you see the tumbling motility? Tumbling motility. It is shown by listeria. Okay, no? Fine. This is shown by listeria. So see here, I have given you so many, like all these motility, all questions related to motility are frequently asked in MCI. Okay, fine. So this can be your one-liner question, but they can ask the question in this manner. Okay, clinically integrated manner. Next question, a 49-year-old male was admitted in one's department with total body surface area 65% involved for 2 weeks. He was on high dose antibiotics. He is complaining of abdominal pain and diarrhea. Colonoscopy findings are shown below. Okay. Which of the following is or are right a statement related to this condition? So when I see this photo, I can see that, please understand that a long-standing case who is admitted in any ward and who is on high dose antibiotics. See, earlier it was mentioned that because of only clindamycin, but now it is shown that any antibiotics can cause this kind of situation. So this is what is happening here. Please understand that long-term use of antibiotics are going to kill the normal flora of our intestine. Okay, normal flora of our intestine. Okay, after that there will be overgrowth of Clostridium. After that there will be overgrowth of Clostridium difficile, and after that what will happen? After that, this is going to infect, this is going to create problem in intestine. Fine. So what will happen then? After that, there will be formation of ulcers, plaques, and there will be formation of a pseudomembrane also. Biofilm will occur there. So that is called as what? So basically, what is the diagnosis? This is called as pseudomembranous colitis. Pseudomembranous colitis. See, this is called as pseudomembranous colitis. Pseudomembranous colitis. Okay, pseudomembranous colitis. So when my patient is having diarrhea because of long-term use of antibiotics, earlier it was mentioned that this, okay, pseudomembranous colitis is happening because of clindamycin only. But now, like this is, okay, proof that any other antibiotics also, okay, those antibiotics also can cause pseudomembranous colitis. Pseudomembranous colitis. Fine, means infection or inflammation of the colon because of extreme uses of antibiotics. So how we are going to treat? Please understand that first of all we have to stop the antibiotic. First of all, stop the antibiotics. After that, which antibiotic should be given for pseudomembranous colitis? First line drug is metronidazole. First line drug, and their drug of choice is metronidazole. Second line is oral vancomycin only. Oral vancomycin. See, this is also oral only. So you know what, when I have mild case, at that time I will give what? Oral metronidazole, or second line drug is what? Oral vancomycin. Second line drug, oral vancomycin. Fine. But suppose if I have a severe case, then at that time I have to give what? IV metronidazole. IV metronidazole for the severe case. Overall, please understand that actually the best medicine for pseudomembranous colitis is vancomycin. This is the best, but actually it is very, very expensive. So we are not using so frequently in India. So that's why actually the drug of choice is metronidazole. So now we can, like exclude all options. Vancomycin is a drug of choice. No, drug of choice is metronidazole. Metronidazole is the best drug. I can say no, vancomycin is the best drug. So option 1 is gone, option 4 is gone. What about option number 3? No, just now we have diagnosed that this is a case of pseudomembranous colitis. So this is not Crohn's disease, fine. Option number 2, Clostridium difficile is the most common organism associated with this condition. Yes. So out of these 4, C is right. C is right. Only 2. Next question. And this is going to be the last question. A 25-year-old male presents with flu-like symptoms, anosmia and difficulty in breathing. RT-PCR COVID-19 is found to be positive. Which of the following is false about the causative agent? So basically, see now here in this question, according to the clinical scenario, I think all of you are understanding that this is the case of coronavirus. This is a case of, this is the case of COVID-19. But now I'm asking you a question of microbiology. So if you don't know the microbiology of coronavirus, you cannot solve this question, right? So now let's solve. The coronavirus, this is a single-stranded RNA virus. See, option can be given RNA virus or DNA virus also. See, this is, non-enveloped or enveloped. See, this is a positive sense or negative sense. See, club-shaped glycoprotein projection. Because of this, shape will be like a crown. Out of these 4 options, which is incorrect? It is enveloped or non-enveloped. Do you remember this? You should solve me. Answer me now. Enveloped or non-enveloped? Please remember this point. This is a single-stranded and the positive sense virus, enveloped virus. Okay, no? So what is answer here? Answer is B. So so microbiology questions are also over. So see here, I have discussed only 6 questions of pharmacology. I have discussed only 5 questions of microbiology. My intention was to give you just basic orientation that how pharma questions can be framed in clinical way, how microbiology questions can be framed in clinical manner. So tomorrow we are going to meet with some clinical questions of pathology, and in this way we shall be able to finish all 6 non-clinical subjects. See, last time I already have discussed anatomy, physiology and biochemistry, pharma and micro over, and tomorrow I will be discussing some questions of the pathology. How patho questions are framed in clinically integrated manner. So in this way 6 clinical subjects will be over, and after that I hope you will be having some basic orientation that how you should start the preparation. That's how you are going to start your preparation. Chalo, fine then. Thank you so much. See you tomorrow at 9:30. All right. Okay, then have a good night. Take care. Stay safe. Bye-bye. Thank you so much.